University of Maryland in the States. She co-founded the Michelle program in 2008 with Michelle Peters and has returned as a volunteer to Eswatini for numerous dental missions. Dr. Wilson has completed an extensive list of continuing education studies in all phases of dentistry and still enjoys learning new techniques. She has a passion for making dentistry comfortable for all and guiding patients towards better health. And then her co-presenter, or her partner in crime, is Michelle Peters, Mish. She is a special education teacher and international baccalaureate coordinator, has been since 2001. She has a bachelor's degree in recreational therapy from Virginia Wesleyan University and a master's degree in special education from George Mason University. In 2008, like I just said, she co-founded the Michelle program with Dr. Wilson and has brought volunteer teams annually from the US to Eswatini. In 2014, she was invited by the Swazi Ministry of Education to work with schools on special education initiatives, where she continues to work closely with local authorities. She is a constant and unwavering advocate for children with special needs. Give a round of applause. Okay. Now, just a little bit of housekeeping before we get started. Questions and comments are welcome, but I think keep your powder dry and save them until the end, because a question might be answered in the next slide. We will have preference for the people that are in physical attendance for questions first, and then we will move on to the ones that are written down on the group. Please ask any questions. Dr. Wilson is willing to answer. Dr. Wilson, do you want to start?
Yeah. So apologies that I may have my back to you if you cannot hear me. Oh, okay. Hopefully if the people online can hear me, someone will let us know.
Yep.
So once again, welcome. You can advance. Why we're here, you've heard a lot. I'm sorry, I am a mover. I am not used to standing in one. So having you all here is very important. Having you all here, attendance to hear about this topic is very impactful, and it's very encouraging. And we'll talk more about that. As was mentioned previously on the housekeeping, you mentioned that, and he also discussed on the Q&A, and also a reminder that the presentation, of course, will be offered as a recording. So there's a lot to cover, and I will move. If I'm going too quickly, I need to hear feedback that it's going too fast. If it's you have something burning, I'm not opposed to you slowing me down and saying, can you please interject, or you have something to say. This needs to be useful for everyone here so that we can all share ideas. So if they come up now, or if you want to jot them down, as mentioned, we can do them. We'll set aside time also at the end. But this really is a way of my objectives here. So we'll discuss some myths and misconceptions about autism and neurodiversity. And I know we have people here that are familiar with this topic. Strategies for early diagnosis and intervention for suspected diagnosis of autism, and be able to recognize the conditions that are comorbid to autism spectrum disorders. Next slide. And in addition, we're going to discuss how to mitigate challenging behaviors in a clinical setting, identify how to implement some behavioral interventions. We'll share ideas on adapting concepts to cultural norms, and then recognize the importance of having support and training for caregivers. And I want to also add some of how I describe things later on in the dental is going to be around my expertise in the dental world, but it also applies to how you interact with patients in whatever clinical setting. So I just wanted you all to listen for that relevance. So as way of a background, you've heard about the Michelo. Some of you might recognize a person or two in the slide on the left. That's from one of our earlier dental missions. Okay, next slide. So you've heard our bios, but you can read it again when you go back and watch the presentation. There I am. So let's talk a little about now. I am not doing all of this talking because as explanation went, she is a specialist in this field. I am a general dentist. I am a care provider. I see people from all backgrounds and all things, but I have a strong interest in, thanks to doing the Michelot project and coming here with the children. So she is going to make sure that the topics, and I am going to go right over there to Mish to help us out. So Mish, they won't be able to hear you. So on the tape, so if you could maybe sit closer. So next slide. So when we talk about language, it's like, how do people want to be addressed? And there's two ways. And like I said, if I'm off, then you give a comment. That's okay. So person first versus identity first. How do you identify? Are you a woman who happens to have autism? Or are you an autistic woman? So there's a difference in how you hear that, how it relates to you. And it really is something that the person that can decide will decide, right? So, but what if you're not able to make a decision? How do you think you would want to address someone? Would you say, I'm a person, they're a person with a disability, or they're disabled? Are you saying, oh, I'm a person with blindness, or you're blind? Or I'm a person with autism, or I'm autistic. I don't know if you can hear the differences there. So identity first puts the person's condition or disability before the person. So it's an autistic child versus a child who happens to have autism. So same thing with autism. And for some people that have the ability to choose, they decide to choose that as an identity. In America, we have identities as well. So we have Italian American, we have what we say African American or Black person. Depends on what situation you're in. Are you identifying yourself as a woman who happens to be Black or from Poland or from wherever? Or are you proudly that where you come from and that is how you identify first? So it's your choice, right? You get to choose how you want the world to relate to you. There are people with autism that don't get that choice. So that's why, from a compassionate standpoint, and I'll say it, that it would be, I would rather refer to them as a person or a child, because I'm going to see the child before I see the disorder. Does that make sense?
Yeah. I would say that goes with almost any disability or any identification of that. That it's not just autism, but I'm a student, a patient that you have with visual impairments or with something. So it's a different mindset.
Right. Yeah, because then you don't want to just see that disability and then you miss the person that's there. Okay. So take some answers on this one. Myth number one. Autism is a very rare disorder. True, false? False. Okay. Of course, false. Next slide. So, of course, it's not. And so, I'm sorry, I'm going to hem and haw because they can hear me? Okay, good, because I cannot stand that close like that. So, in the US, do some statistics here, facts and figures if you like. So back from 2020, CDC said 1 in 36 children in the US have an autism diagnosis. 3.8 times more prevalent in boys, and that number has increased significantly, right? And I think we'll see that a little later. But important that it's diagnosed later in certain populations. So, and we all know early intervention is so important. And so when that doesn't happen, and we'll talk a little bit about that as well, but how can you make a difference with that child? And so when we talk about diagnosis, we're looking at how quickly can we see and make a difference. And so there are things you can do. But it's getting later in Hispanic children, later in children that live out in rural areas. Access to care is an issue. And if they have public health insurance, they're not actually getting access to that kind of information they're provided. So we've noticed that here in the US, not well with me. So Eswatini here, the statistics say in 2017, and this is where you all can jump in because this may have changed, that the people from ages 5 to 19, it was 13% of those people in that age category. And if you, 25,983 is what was reported, and they're living with some wide variety of all disorders. And then the prevalence there, what's different is that there was not a number that they could acclaim to autism spectrum disorder. So if there's any update on that information, now would be a good time. Anything to update on that, or is that still the case? Still the case?
I know earlier we were actually talking with some of the clinicians in the room that they were saying that it's actually growing and it's becoming what, the number 1 or number 2?
I think in a month we see like maybe 4 autistic children at Soko's clinic. But the true month actually weekly. Yes, that's why I'm saying it's 4 weekly.
So a growing number are being seen in your clinic.
Yes.
Right.
Yeah, and I know the prevalence is, and you might have some information about that too with early identification and what you're seeing.
Hi.
Hello.
Hi. I'm Bree. So I work with kids up north. The ones I work with are specifically CPs. And a lot of the statistics are showing that CP is currently the #1 childhood disability that's not being diagnosed in kids. But autism, ASD, is quite high up there as well, and it has been growing in the past 10, 15 years. But I don't think it's that it's actually growing as a condition. I think it's just people are learning more about ASD and learning how to see it in people, in like young kids, and learning how to identify it. And when you do identify it earlier, you're going to start seeing more and more kids who have ASD, but not in a negative way, but it's because more people are getting identified and less people are slipping through the holes. Right. So in a lot of ways, people think it's becoming more common, but really I think it's actually just being better diagnosed.
Right, very good. And you can see that worldwide that's happening, right? The statistics are out there like with different countries that you can see over a span of time. And the countries that are able to diagnose, the numbers are high. The countries that don't diagnose, of course, the numbers are going to be low. And that's not necessarily how it's out with the true numbers that were being tracked. So we're getting better at tracking, which makes the numbers go from, in 2019, it was 1 in 160 to now it's 1 in 100 children worldwide. And that's basically due to our efforts of trying to identify it there. So number 2, people with autism are nonverbal and significantly intellectually disabled. Oh, yeah. It's not an absolute. People with autism are all over the spectrum. They could be anywhere on that. They could have high social skills, but maybe their executive function is low. So they are very kind and open, or maybe they have sensory sensitivity that's off the chart, but their cognitive function is very good. So you see them all over the map. So about 38% of them, though, do have some sort of intellectual disability. And then the rest have about, as it says, average or above average. So that leaves a lot of room for kids to be pure normal. Now, the smarter you are, the higher the IQ, they're saying the later it's going to be diagnosed because the kid's functioning. The kids, I have a nephew, and when he was little, his mom was so excited that he take numbers, and he would stand at the refrigerator, and he was a little toddler, and he could put the numbers, and he knew what he was doing. And there were other things he could do, but yet you take him outside and he goes into a room and there's he hears something or he hears conversation, he's covering his ears. And then you try to go to a restaurant and he's screaming. And it's like, what is wrong with this kid? So we didn't know, right? So they worked through that, and he got sorted, and now given his sensitivity to sound, he now plays in a drum line at his high school. So he's in high school. So he has come a long, long, long way, but it was definitely early intervention. People with autism don't make eye contact, smile, or show affection or emotion. Right? It's smart crowd. So when we talk about the core symptoms of autism, one of them, and a big one, is social communication challenges. Is that person able, or do they have difficulty? And that's what we see, difficulty with verbal and nonverbal communication. About a third of them are nonverbal. And they probably have trouble making eye contact or their tone of voice. So they definitely will experience some social challenges with that. So they have difficulty recognizing, like in a situation, a person who they're looking at, they can't read your emotion, like they can't pick it up, whether you're upset or you're happy or you're sad, like they may not do that or may misinterpret it.
And this is like particularly, I found this with my students during COVID. Is a lot of the kids, they try to navigate with coping skills they've developed, especially with facial features. And when we had COVID wearing the masks, they could not pick up those little tidbits that they learned. And so when you think about being in your doctor's office, what are you all wearing every day? So when you think you're wearing your mask, they cannot see whether you're smiling or frowning. They can only read what usually, if you have really expressive eyes, which many of us don't have.
Or we're wearing loose and then they can't even see our eyes.
So they're literally looking for any cue as to where they stand or what to expect, and they see no information. And so what do you think their reaction is going to be? One of fear, right? And the unknown, and they're already navigating in a world typically where they're trying to figure out where they're fitting in, which is why they do a lot of the stemming. And, a lot of the kids with a multitude of disabilities. I mean, human nature ourselves, we all stem. We all have tics. And some of us just have more socially appropriate tics or subtle tics. So that's something to remember that we all have that. Oh, sure. So a lot of times you might see a child who's flapping, right? Some of the kids with autism might be flapping, or you might see them doing some things with their mouth, or you might see them sniffing the air. You might see them doing something that's like kind of odd, right? That's socially not normal per se in society. And this is the other thing to think about is cultural norms. In America, we see it because our cultural norms are very different. I learned that here in Swaziland than Swazi cultural norms, right? We're a big country on complete eye contact. So if you're not making eye contact with me, we're in trouble. There are cultures out there who don't make eye contact at all. So when you have a child who's usually stemming or with their tics, that is basically them finding a way to navigate where they fit in the world at this time. And like I say, we all do it. How many of us sit and we have our legs crossed and we're tap our foot? That's stemming. That's a tic. I know I have one, like when I'm nervous or I'm talking to somebody, I'll play with my necklace and I start separating my little things here. That's my own kind of subtle way of just being like, calm down, you got this, you're cool. But we all do it. And so, and different kids do different things. Not all kids do this. Not all kids flap. But like I said, sometimes you'll pick up on those things. That's why it's really important to know your students, to know your patients, to know what those mean. Because some of them, you're going to look at them and be like, what are they doing that's kind of bizarre? Like I've had kids who are like, they're sniffing the air. And you're like, what are you trying to smell? That's just the way they're trying to navigate the world and where they fit and where they feel safe. So does that make sense? Okay.
Mm-hmm.
Yeah.
Okay. Next. Okay, number 4. People with autism are inflexible and or engage in rituals, as well as unusual behaviors such as hand flapping. Well, we know the answer to that, right? So it's both. It's true and false. So some do, some don't. So the second core symptom of autism I have here, restricted repetitive behaviors. And as she mentioned, it can vary greatly over across the spectrum. So there's an example up there, the flapping that she mentioned that. Some might draw or doodle. Now, echolalia. Echolalia, okay. So humming, repeating sounds, or maybe do they repeat what they hear you say?
Sometimes.
Yeah, that would be the echo, I guess. Okay, I've seen that, and they go, or whatever you say. Twisting your hair, I'll do that too. Swinging or rocking, you see me going back and forth, right? Fidgeting, somebody mentioned that, Mish did. Okay. So now neurodiversity has come up because that is a kind of like the watch word or the movement, so to speak, and that's to create a big enough umbrella, right, to recognize people that are just wired a little differently. And they, again, there's a whole big spectrum. If you look at all of the different things that appear on that wheel, they would fall under neurodiverse people. And autism's a part of that, but they also can have co-diagnosis, and we'll talk about that as well. So how can we make the environment around these kids and people more easy for them to navigate? What can we do? So some of the things is just being aware, right? So if you're aware of it, you know, if a person has sound sensitivity, then you kind of prep them, you prepare them. There's going to be communicate in advance about this loud noise. The drill is going to start now. You're going to hear, you know, it's going to be noise. Or what other, they could put on so the way you can do it, of course, offer the headphones, like I mentioned with my little nephew, great nephew actually, that they put on the headphones, and then he could go, because he couldn't even go into a public bathroom. And when you think about the reverb, you know, when you're in that tile in the bathroom, that sound, oh my God, it would be just like being in the noisy restaurant. He would just go crazy. So she had to, and he learned how to ask for his headphones, because as he was going through elementary school in his early years, his teacher would say, do you want to put on your headphones? Or he would actually go and ask, I would like to have my headphones. So he learned early how to manage, and there was a lot of intervention that went into that to get him to that point. Some people have tactile issues. They don't like the way things, like their clothing, if it touches them in a certain way, or materials. If it's wool, I hate wool, the scratches. But you know, some people have sensitivities all over, and you just wonder what's wrong with this. You know, why are they reacting? Like, take this bib off. They might do the activity, but you don't know why. Like, why are they ripping that off? Because they didn't like the way that felt on their skin, but maybe they couldn't articulate it. So you have to kind of be aware that, find out, ask the parents what's going on, or the caregivers. How are they at home? So movement, some of them need to move. Like I told you before, I told you up front, I need to move because it's hard for me to just sit here and talk, because my body is going to want to move. So you ask them, so what do you need? Do you need something to hold, the little fidgety things, the toys that the kids had earlier? Do you need a break? Do you need to be able to sit in a different chair? That sort of a thing. So accommodations are key.
And in many of these situations, you have hypersensitivity and hyposensitivity, right? And there's a huge difference. And so something to be cognizant of, and this is where the caregiver is imperative, is understanding where that person is. Because when you think about, as we know, any person that has a disability of any kind, think about someone who's visually impaired. What do we know about people with visual impairments? What is their hearing like? Hi. What is their touch like? Hi. Our body naturally compensates when we lose something. It's a survival skill. It's a basic survival skill of humankind. So when you think about when you have those situations, if you're hypersensitive, it means even like having that bib on and that crinkly sound can sound like the speaker when it squeaks to them. It can be so irritating that they cannot handle it. Just like if you have somebody who's hyposensitive, I mean, I've seen students who had gashes on their face and they don't even know they're cut, and they don't feel pain. And that's something you need to know as a medical professional too. So when you're asking, oh, does this hurt? And they're like, no, but you really have to be cognizant of that because they could be bleeding out, right? And so those are all things you have to be able to navigate and understand, as well as their sensitivity to certain parts of their body. So every disability, like there are certain disabilities where you might have children who've had feeding issues as they're getting older or as they're younger, where they were fed and forcefully fed. Well, do you think they have mouth issues going to the dentist if they were their entire childhood forcefully fed? I guarantee you they're probably going to be resistant having you go in there with some prickly things to go in there because they're hypersensitive or hyposensitive. So it's just to navigate and knowing that the difference between hyper and hyposensitivity.
So what are some things we can do? Get those, have your instructions, give them the expectations, to tell them, show them, do, use whatever techniques you have, break it down into small tasks. It's hard, and we know we're trying to get things done. And sometimes we have to back it up and slow it down. So. Oh, I'm sorry, Maria, I forgot. She did have her hand up. Thank you for being seen.
Just to add one little thing to neurodiversity and accommodation, I think something that's really important to recognize is very often we as individuals have our own differences, individual differences, that make a lot of the points that were on the last slide beneficial to everyone. It doesn't have to just be someone who has a disability. And so, and I don't know how many of you work in town or in community or how it works, or people on the screen, I don't know. But especially with kids in like the communities who haven't had access to the luxuries of town, a lot of those kids and a lot of those individuals haven't been given the opportunity to figure out what works for them. In the schools they're forcibly put into situations, forcibly put into uniforms that feel a certain way, no option, forcibly fed certain things, even if the texture doesn't work for them. In clinics, they're stuck waiting in a very long line, in a very long room, and then they get in a very busy room, and then they get sent in and seen really quickly, and then moved to the next station. So when thinking about ways to support neurodiversity in general, but also in school and workplace and home, one of the things that's most important is recognizing it's not just kids or individuals with disabilities, because a lot of those topics can be like beneficial to every individual. And then we're making it more about individual differences in every person rather than, oh, this population here, they need accommodations and they're not the normal kids. So trying to recognize that it's not just about the ones who are more visible, but it can be beneficial to all the students, all the children, all the people.
Thank you. 100%. Okay, so now a little bit on diagnosing autism. So if, again, I mentioned this, like the early interventions, the earlier you can start looking, the earlier you can pick things up, the greater opportunity you have to help that child. By 6 months, if you see a baby and it's not smiling or not smiling very much, or they don't seem like they're happy kids, you by that point you should have a little kid that can at least give you some smiles. Or maybe they don't make a lot of eye contact. They're looking off, they're avoiding you. And by 9 months, if you can't, usually you can kind of cuckoo, you can make a little sound and they may parrot it back. But if you're not getting any of that kind of sound going back and forth, smiles or other facial expressions, yeah. So by 9 months, they're usually able to do some of that. You can say, "Smile for mommy," they give you a smile. So by 12 months, if they're little or no babbling, now that doesn't mean that their language is perfect. It just means you don't really hear them doing much of anything, because sometimes they're speaking gibberish, but at least they're trying to have speech, right? But maybe, again, the little ones, sometimes they might not be able to say they wanted juice, but they can point to that juice. They want you to give that to them, right? So if they're not doing any of that, or they don't respond to their name, or very, like, it's like hit or miss, you know. You're calling Junior's like, you know. So you do want to pay attention to there. By 16 months, you're really expecting them to have some language, some vocabulary. And then by 2 years, you're not even getting those 2-word phrases. So, you know, that's where you start saying, oh, this language is really delayed. So those are some of the key points I wanted to make out. And then at any age, you know, even when they're older, you could see some things. They might lose some of the things that they did before. And they say, well, I used to do this. And this, you know, they'll tell the pediatrician or the doctor, but then they stopped, right? It's like, what's going on? That's a great question. Want to find out. They start avoiding the eye contact, and they just want to be alone. And I'll let you guys read that. I don't want to have to read all the slides, but when you see things that are just not showing up, yeah. And then some of the physical things you start noticing there too. Okay, so some of those symptoms, it kind of goes back to what we talked about, 4 symptoms for autism: the social communication challenges, this restrictive and repetitive behaviors, trouble with transitions. So it's like, oh, the routine is set, and now you want me to do something else. That's not what I normally do now, right? So then you have, they're just not cooperating with you. Like, again, the not being able to read or understand, are you happy, are you sad, mommy, you know, like they don't know. And then the sensitivity, light, sound, taste, touch. Okay. So when do those symptoms, of course, we talked about early childhood, they can begin, but sometimes, like I said, the more intelligent child knows how to navigate the world without using his language, or so they kind of get away, or they have limited language, or say you have siblings that are older than you that go, oh, he means this, or they speak for him. That one, you know, the brother John, whatever his name, he wants this, or he wants that. And so they have that little code of, they understand him, but he's not being very verbal. And when those systems persist and when they interfere with daily life activities. So, next.
Sorry.
Yes, go ahead. Yes. Oh, and introduce where you're from so that they get the context.
Oh, yeah, sorry. So I'm Bree. Like I said, I work up north at Vusum Notfo. At Vusum Notfo up north. It's a small local regional NGO that works up north. And we do a lot of different things, but we focus mostly on both basically child development and looking at how can we utilize the parenting and the community dynamic to kind of get over the negative cycles of dependency, in a sense. And a lot of what we focus on, with me at least, is working with kids with different disabilities. And I don't specifically work with kids with autism, but I do a lot of, what's the word I'm looking for? A lot of awareness and screening that has like certain questions and certain aspects that allow you to see if there's some of the warning signs on the prior slide that was on. You can kind of like pick those things up. And in a lot of situations, those early signs are for more than just autism. So like one of the kids I work with, like I said, CP, which is cerebral palsy, almost all of those early identifications are visible, right? So you can see that stuff with a lot of kids in general. And there's lots of different resources that you can use. I use something called Brigant's Inventory of Early Identification, but there's a lot of different resources you can use. You can find different resources on the internet that can help you figure it out. But it's all about kind of determining, is this child developing at the proper, like, normal rate? And if not, then that's when you want to get early identification and figuring out what's going on. And it's really basic stuff you can pay attention to. Like, what is my child supposed to be doing at 3 months? Are they achieving those specific things? And so early identification, if you don't like have it, you end up experiencing disability to a whole nother level. So a lot of the kids I work with are like 9, 10, 11, and never had access to early intervention, early identification. And their disability is so much more extreme than it could have been had they had access to the resources and the early identification, early resources that are more available in town, which is really awesome to have resources. But yeah, so early identification and such is super important. And a lot of it, depending on any of the disabilities, you can really just look at, is my child developing at the average normal rate?
And to go with those resources too, like what Bree was saying, is like what's great about the grants or other assessments you use. As you guys know, as doctors, you can track when there's setbacks, right? Or when there's growth. And so that's important to track, so you can have that, and that helps the whole team,
Right.
with anybody and what they're doing. Yeah.
Okay. Let's see, for the physicians on the line or medical people, the diagnosing autism and the DSM, this is in the US, I don't know, the DSM-5, autism diagnostic criteria. Do they use that here? Yes, okay, thank you. So I won't read all of that, it's there because it's very detailed, but it basically, the bullets are, the social communication, is that persistent? And do you see it, and then capturing where that happens. With the movements, the restrictive repetitive movements, or patterns of behavior, interest, they start shutting down. Next. The systems must be present in the early developmental period, but it says it, and this is why I hate with the DSMs, because it's like if it's not that, then all of a sudden it wants to say, no, it's not that. So some people tend to fudge it. But anyway, so symptoms are supposed to be present there, okay? The symptoms cause clinically significant impairment in the social. Well, there's a spectrum of disorder. So there's actually a grid that says it's like, I think, is it 2 out of the first, I saw this thing where it was like 2 things out of the first category and then 1 out of each of the other. So it wasn't like all of it. It wasn't all of it. And so I would just point you to the DSM because there's abbreviated forms, but I just put that in as a reference there. So, okay. So if they have, some of them might show up as Asperger's on that spectrum, but of course they might have low social skills, but very high intellect. I think there's another slide on autism. So you can go to the next slide, unless there's a question on that. Okay, because I wanted to talk about a little bit on Asperger's. Yeah.
Also, when looking at the DSM-5, make sure if you are not certified and qualified to use, working with someone who does, because you can easily misdiagnose, and the DSM-5 is very, very specific and it has very different qualifications than the older versions do, specifically because it was designed for infants and early children. So if you are not the qualified person, you need to be engaging with someone who is. It's not something you can just download off the internet and start diagnosing with. Like, it is very, very specific, and it is very specific for very important reasons.
Right.
So.
And the key thing is being aware of the signs and the symptoms, and then getting them to try and get a diagnosis. So Asperger's, a lot of people, may have encountered people with Asperger's because they have some great strengths. They can be very focused and persistent in doing a task. So for some jobs, you'd love to have someone with Asperger's because they're going to detail it down and keep going with it. And they are good at picking out and the attention to detail. So a lot of them are good with computer work. I don't mean to make that as a generalization, but if you think about the skill sets necessary. But it also could include the hypersensitivities. They may not engage in a conversation. So I have a cousin who was diagnosed with Asperger's, smart as a whip, but you couldn't get him to sit down with you and have a conversation. And he's now in his mid-30s, high 30s actually, But now he can. Right now, I was like, oh, so when I ran across him again, and it's like, oh, hi, cousin Lois. Like he had an actual conversation. But there were years where he just, you weren't going to get anything out of him. But he went to college. He was at the University of Virginia because his dad was like, well, he can get in. Yeah, he can get in, but socially, it was a flop, So he just quit and went and played video games. So, but he was smart enough to get in. So anyway, so you'll encounter those, and of course everybody is on a spectrum. This is not, in the U.S. anyway, it's not a separate diagnosis now. It's under the autism spectrum disorder. So, but there was a term of that, Asperger. So what causes autism? I don't know. I'm gonna say I don't know. What I read was we don't know. And so if anyone else, what I did find out that there are some genetic risk factors. Let's see, where's my notebook? I'll be able to give some more details on that in a minute.
So as there from you can see, it's like, so some of the risk factors are, it can run into, think about there's a lot of genetic pieces to that. I mean, the Fragile X syndrome has a big piece to that. There's a lot of research around that. Environmental risk factors, they're finding a lot of the things in our food with our, genetically altered food is really going to come to a head where it's causing a lot of medical problems for people with, having those pesticides put into the seeds of our food. So we can't even get away from it. So, and not to mention the hormones in our meats and things like that. So there's some factors there.
And then some of the good things that are going on is that you can help decrease the risk. And that has to do with the folic acid, the vitamins, that folic acid. I'm trying to have it in here. So that's the good news. So there is some hope there. Things we can intervene and do. And then of course our food source. So you can. So there's a laundry list here, so I don't want to bore everybody with this. So, but let's see. On the comorbidities. So we talked about already, like there can be a co-diagnosis. There's a lot of things that show up in a kid with autism. So what are some of those things? GI disorders. So things like chronic constipation, abdominal pain, having gastroesophageal reflux, and bowel inflammation. So that can show up in a kid with autism. Autism in an epileptic child can affect up to 1/3 of autistic kids or people in the autistic population, but epilepsy only shows up about 1 to 2% of the general population. So it's very high. And I think as the older they get, the more that will tend to show up. The eating disorders, about 7 out of 10 children with autism have eating disorder. Some of it is they extremely restrict the foods that they will eat because of the whole taste or the texture, or they just refuse, they aren't going to eat certain things. That can, of course, cause all kinds of problems.
So like think about that as a clinician when you're putting, what did you call it? A tongue plate? Tongue plate. Yeah, tongue depressor. You put a piece of wood in their mouth. And if they have those sensitivities, or if you put some gel in their mouth, or like the tooth polish that's gritty, those all things are going to be something that could be really severely disruptive and disheartening for all sorts of people with sensitivities.
And they can also experience obesity from chronic overeating and eating non-food items. And that usually shows up in those with severe autism. They'll tend to eat all sorts of random things.
I think also something, going back to the dental side of things, specifically in Swaziland, something I've noticed in my work in the communities is how parents with little kids will just try and force feed their kids if they're not eating fast enough, right? And they'll try and be like, well, just eat, finish, like you have to finish the bowl, and like try and force it down. And in some situations with kids, especially kids who have sensitivities, who don't have as much tactile function, they're probably sitting there being force fed, right? And so when you think about it, if you see a client, a young kid, who every time you go towards them, they turn their head. Every time you try and go toward them, they turn their head. Realistically, you should engage with the caregivers, find out, is there something more to this? Is this related to early childhood feeding issues? How does your child eat? Because when you think about it, similar to what Mish was saying, no one likes going to the dentist in general with stuff put in their mouths, other than dentists maybe.
Other than my patients, they love it.
Well, fine, sure. But like people don't like stuff being stuffed down their mouth. And if you're coming from a situation where as a child you were force-fed because you either weren't eating fast enough or you didn't want the food that was put in front of you, it's going to be super traumatic. And then that, with all of these observable traits, can cause a lot of additional difficulties with swallowing, with your obesity versus not getting enough food. And that's why in a lot of ways it's always good to engage with like a speech therapist if you're noticing these things, because this is where you need to have that holistic approach. Because a lot of these kids are having these experiences, and if they keep turning their head constantly when you're trying to put things in their mouth, look into like, what are my other options? Because there might be something more going on here.
Okay. All right, I'm going to, and just as a way, you will get copies of these slides. So I'm just going to pick out a few things that and these are more things that parents might notice too. So maybe they have sleep problems. About half of children would have sleep problems, and when they get older, 4 out of 5, could go up to 4 out of 5 of those people have sleep problems. ADHD, 30 to 60% of people with autism have ADHD, compared to 6 to 7% in the general population. And then for anxiety, like 42%, up to 42% of those kids have anxiety issues, where it's 3% in the general population for children, 15% for adults that's recognized that have anxiety. Depression, 7% of autistic children and 26% of adults with autism have some type of depression, whereas in the general population, 2% of children and 7% of adults. So there's also, you see schizophrenia with autism. It usually, that usually shows up later. Of course, we know in early adulthood, like the 20s, late 20s. Bipolar disorder. Thing to note here is that those symptoms can, of course, overlap with autism, and if they're on medication, the diagnosis is key, because they could be prescribed medications for the bipolar disorder, and that actually could be a problem for an autistic child or person. And Down syndrome, 16 to 18% of of kids with Down syndrome have autism, or they're on the spectrum. Okay, and there is such a thing as that dual diagnosis of Down syndrome, ASD, autistic spectrum disorder. Next. Now, there are, when you get more into on the medical side of making some of these diagnoses, these are some things. Fragile X syndrome was brought up. Gender dysphoria, that has a higher percentage in the autistic population. The vitamin deficiencies. Now, I'm sorry, I don't have my notes on that one, because I mentioned the folic acid, the B9, is something that would be helpful. And then I believe, I want to say, is it, in some cases, if it's zinc, that if it's too much, is that detrimental? Does anyone have an answer for that one? I'll ask the audience online if they want to chime in on that. But those are some of those comorbidities that you might see. Okay, so now considerations in our environment, in our everyday environment. So what are some things we need to know as clinicians? And from a dental standpoint, if you look over here at the side effects, and those are on the drugs on the left. So if they're on central nervous system stimulants, the dry mouth, xerostomia. Antipsychotics, xerostomia, dry mouth. Antidepressants, xerostomia, dry mouth. Anticonvulsants, xerostomia. Antihypertensive, clonidine, xerostomia. So I just point that out that every single one of those can show up. So if a patient comes in and you're wondering why their mouth is so dry, and then of course they can have some of these other things as well. Trouble swallowing, discolored tongue and bruxism. We all know people that sometimes have too many of those. At least I see a lot of those up at home. And excessive bleeding. So you want to be careful. Prolonged therapy of medication combined with aspirin or nonsteroidal anti-inflammatory drugs, NSAIDs, may result in excessive bleeding due to thrombocytopenia and leukopenia. Okay, next. So what are some other things we talked about already? So the commonly prescribed, that someone can pronounce this for me.
Fluoxetine.
Thank you. Fluoxetine can cause serious allergic reactions. So you want to look for that. Swelling, tongue, throat, and face. That could make it difficult to, of course, provide some oral care. Local anesthesia with vasoconstrictor, so no epinephrine. You don't want to give that in a person who's taking methylphenidate. So, and they use that a lot, as it says, for hyperactivity, as it could cause tachycardia or a hypertensive episode. One thing, note, institutionalized adult autistic individuals, were studied to find a higher incidence of periodontal disease, but they exhibited lower caries rate. And usually as a child, they're gonna have a higher caries rate. So they have poor tongue control. The food just kind of mushes around and stays in there. And some of it was related to diet. The older they get, like if they're a restricted diet, that maybe they're not eating those carious foods. So, or the texture, they don't like the certain textures. They're not going to eat sticky things. So that kind of there. Looking for the delayed tooth eruption. Could be hypertrophic gingiva. And that could be, of course, caused by the phenytoin. Of course, the bite. One thing to note on that agabal, if I'm saying that right. We don't use that. I don't use that word. You see a lot of, that's the high vaulted palate, very narrow, high vaulted palate. And the incidence of that, of course, is crowding and it causing an open bite, but it's also linked to SIDS. So there's a lot of, when they did like autopsies on kids that died from SIDS, sudden infant death syndrome, they stopped breathing, they had that high palatal vault. So if you see a kid with that, or if you know young babies, keep an eye out on that. And the bruxism could be caused by those medications. Tongue thrusting, lip biting, they don't have control. We had a kid bite their lip, but they were numb from the other day. Okay, behavior challenges. So this is where we're going to get into. So what does that look like? And it's not a to B, B to C step. A, B, C means something else. So let's just go through. So hyperarousal, you might see that. You might see some discomfort from something going on. You might see, in this scenario, they react. They have this emotional response. They start screaming. They start moving around. And then they're going to be motivated to get out of there. They want to avoid it. They're going to move around. They're going to thrash around. Now, they're going to try to escape. And they will go even if it's going to hurt them. They are going to go. And so what happens? They make that escape. The behavior is reinforced by you taking them out of the environment. And then that stops the distress, but it also reinforces, if I act out, I can get out. So that's kind of where you really have to look at, as Mish mentioned, the A being the antecedent. What was there before? So you saw something, you saw a reaction, you saw a behavior, but what was it that may have stimulated that behavior? And then, so how do you mitigate like the consequences of that? So, Mish, do you want to add something?
Sure. I mean, like we saw that all, I'm sure I see it in my classroom every day. I'm sure you see it in your clinical settings, right? Where you have, a patient that comes in and, they're feeling uncomfortable. They start getting anxious. No, you've never seen anything like that, right? In your surgeries, you've never seen anybody get nervous or whatever, right? Well, think about that. That nervousness comes from a learned experience, probably. So that it's a past experience or something. They are feeling fear or something happened to me last time. And so
said it was going to be
something
hard,
or whatever, there's some preconceived something, right? Or they see a needle flashing in front of their face. I know if I see a needle flash in front of my face, I'm out. Like, she's my dentist, so she knows, right? So then you have that behavior. And so sometimes that behavior is one that it's going to escape, or it's going to be a reward, or I'm going to do this because I know what the consequence is going to be is I'm going to get to go get my toy from the toy box, right? That's how I got to the dentist when I was a kid. I knew I was going to get a toy from the toy box if I got it. Now let's think about this. You have a child who is freaking out. They see they're going to, like, we'll say, I'm going to pick on the dentist. So they're going to the dentist. They know they're going to be uncomfortable. They're probably going to get a pinch and it's going to hurt and they're not looking forward to it. And so they start getting obnoxious and crazy and they start getting really whatever. And then they're like lashing out. And then they're like, okay, I'm just going to let you go. Right? You've just given them the out. Right? Now there's a fine line because there's also the, where do you fine line and say, nope, you're sitting down here and we are getting this done today and it's going to get done now. There's a fine line between that of what you have to do. To me, like as a medical professional, I'm sure is this life threatening or is this something that maybe we can wait on? I know a lot of my students, they'll come in and when I know they're going to the doctors, we train them at school to kind of help them get used to it. So they'll come into class and we'll say, okay, this is what's going to happen. We practice going to the doctors every day. And then they get to leave. And they have that positive, like, oh, it wasn't that bad. Then the next day they go there and they're like, okay, open now. I'm going to put the little tongue depressor in there. Blah, 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 blah. And they're like, okay. And then they leave. They're like, wasn't so bad. Right? Then they go in there that third time. And like, okay, I'm ready to be there. Hey, yo, doctor, like, hey, I'm here with you. Like, and they're ready to go because they know they have this positive reinforcement that's coming. And so, we all know the whammy's going to happen, right? But then it's like that balance of being nurturing and making it so it's not always a bad situation. And so you want to make sure that consequence isn't always a negative. Because you know what? If you have that negative consequence, are they going to be coming back to you? They are certainly not going to come back to you because they're going to avoid it. And then that could be life-threatening. And so it's like a fine line, right? A fine line between being coddling and over nurturing to like, you got to get this done, right?
So where do we begin? Before the visit, of course. Because then we have an opportunity to modify and affect the behavior during the visit and then after the visit so that there'll be a next visit. Okay. So what are some of those things? So we talked about some of those. You can use a pre-treatment assessment form. So in your surgeries and your clinics, if you have that information, that it asks if you have a survey, and we're going to provide some examples. I don't know, do people have pre-assessment forms that ask, like for children, those behavioral background things? Like, has your child been diagnosed with X, Y, and Z, or is there a history of X, Y, and Z? Okay, so think about that. That could make a difference. You could meet with the caregiver. Who's the person that's, responsible for this child that you could then have a conversation with and go, okay, tell me what's going on. Does it have to be you? No, you could actually have a trained staff person screen these people. So I know our schedules is not that we're going to sit down and do all this on every child. If we have the staff to do it, we train them, they can do that. They can give you the heads up, go, okay, and then you have a protocol that will, as a plan, but you consult with the people of their environment. So, okay. So we mentioned this, I think some already. Associate the visit with good things. Associate yourself, like, oh, okay, this is fun, I'm here. Are things there? If you do an assessment, look around your environment at the clinic, are there scary things on the wall or are there fun things? You know, you just kind of, and let the kid, there's the kid playing, like pretending on his little, it looks like a bear. And you provide accommodations, sunglasses for bright light. Actually, all my patients get sunglasses because I wear a headlamp and I'm just automatically, my staff knows they need to have the glasses in their hand and the bib on when I walk in. Do you have different flavors? You know, can you please everybody? No, but you can at least kind of see where you can. I'm not saying anyone's going to do all of this stuff, but if your population in your practice are these special, or would you say neurodivergent would be the word, then you might want to have some of these things in your practice. So the X-ray, the lead apron. I have adults that say, can I put that on? Like they like the feel of that weight of that lead apron. It gives them some security. Kids don't usually mind unless it's a negative for them. For some, it's a positive for them. And you just have to ask. Why should that? Okay, next. So if you have the capacity, or if your caregivers have a capacity, like we said what the teachers are doing, they're prepping them up. Like I said, a lot of this can happen before the visit. It doesn't mean that the whole world is like depending on that visit. It's like, no, what's going on before the visit? Do the parents have books that they can go over with the child and show them what's going to happen, or give them at least an idea and practice about that? So the first then statement. So it's like, first we're going to do this, I'm going to do this, and then you get to go home. Or first we're going to do this, and then you go to the toy box. Or first you're going to do this, and I'm going to make you a balloon out of a glove, or whatever that is, that you want to do something that might work for them, but just make sure it motivates them. Okay.
And if it's something, I would also say in your practice, if you've noticed some students, sorry, I'm a teacher. If you notice some clients that they may or may not, like they have trouble opening mouth as wide as you need, or spitting, or, you know, if you're a medical doctor moving in a certain way, then it might not be a bad thing to give their caregivers little pieces of information for those to practice at home. Like every night before bed, let's practice and open up your mouth so I can see everything. Let me see if you brushed good. Those little practice things will make it more of a normative behavior as compared to one that's now going to be attributed to a negative. So those little things can help you with your practice by having them to be done at home.
And a lot of it is just, you could do that for all of your young patients. The parents, give it to them. They don't have to be with a diagnosis. It could work for every kid. You know, here, this is what we do. We give out this pack. We're going to give you this. Technology, email it to them, whatever, text it. Distractors, music, videos, whatever, if you've got that. And of course the conversations, like special interests. What is that kid, you know, we talked about that some of them have like fixate. They might fixate on certain topics. Well, then maybe, like I said, again, on that assessment, that pre-appointment assessment, you could then ask about that. So then your staff would know, oh,
he likes cars.
You like cars. Okay, talk about cars. And that's all. Okay, we don't talk, you know, and then you just bring it up. So, and that's a strategy we use on all the patients. So not just them, communication with that. Is that something, I don't know if you guys do that or not, I'm assuming. So give choices and allow breaks. Okay, that's a hard one. You're busy. I guess it depends on how many surgeries you have. If you have this capacity to do that and offer that, to allow them to take those breaks. Forced choice. It could be, you can choose A or B. Do you want me to do it this way, or do you want me to do it that way? Because we're still doing it, but you get to choose how we do it. Okay. So, and of course, don't react to the problem behavior, because then you feed into that, you reinforce that. So you try to just not get the reaction that they are trying to elicit, because that's a distraction. So if I can get you to, be upset, then it takes the pressure off of me. So praise the behaviors that you like. And reward compliance. So that's, if things have gone downhill, then you want to try to bring it back. So you can, again, doing the take turns. If you can't do it with and I've done this, if I can't get a prophy angle in there, then okay, we're going to do it. We're going to use a toothbrush. And we're still calling it, you got your teeth clean, because I put the prophy paste on the toothbrush, or sometimes it's toothpaste, or sometimes it's nothing at all. But to the kid, they got their teeth clean. So I got that accomplished. Okay. Oh, you can. So have a family plan. This is really important. So having the family with a plan, when you can, it goes back to how do you prep them up to prepare? How do they deal with them afterwards? Because the language that they use afterwards needs to be positive and reinforcements. Look what you did. You accomplished this. You sat through. I'm so proud of you. You were able to do this. And so, let the parent know. I got kicked out, so as a parent. So, that is the parent exhibiting good behavior. So you want to make sure that you train that parent, right? So that they're doing something well. So you want them to be on board with how things are going on. So, yeah. And people have their own, I know people in the US just don't let any parents go past the door, right? You can't go back into that wing at all. So it just depends on how you have your surgery, what you have. Make sure your parent knows that going in. Okay. Scheduling, that's a tough one again. Can you limit the wait time? If you know that kid's going to get anxious and frustrated really quickly, then try to schedule them at a time where you can get them in and get them out. And it doesn't disrupt your day, and it makes it easier for them. So is it the first thing in the morning? Like they're the very first patient, so you're not going to run behind. You just get them in, move them, get them out. Okay. Less busy times, whatever that is for you. Okay. Or right after lunch or whatever that is. So I think that's where you talk with the parents. When are they the most cooperative? They know their kid. They know, well, he's usually good after his nap. Okay, good. Let's do it right after that nap. Okay. All right. So now document. So if you can capture this information, it will go a long way. Because then Misha mentioned earlier about sharing it across the platforms of providers. So what worked, what didn't? What do you want to have in your office? Have a plan. What do you, who's going to do what? Assigning the roles. And kind of outline what your expectation. So do you expect them to be able to get X accomplished? Are you asking too much? Maybe we need to cut that back, or we think that we can get more done. So like with your treatment plan. So, and then there's a behavioral treatment plan there. So that would apply, to our specialists on the line. So we want to find out from them how they feel about that too.
I think setting up that physical space is imperative, because it might be a smell, a scent that might calm or offset someone. I mean, I'm just talking about the general populace. It might be, I'm very light sensitive. So if I go into a very brightly lit room, I'm already like, don't touch me. So those things to consider, turn off the light if someone's light sensitive, especially, some of the people that we work with, like their visual impairments. Imagine being visually impaired and someone just grabs your face and starts poking you with stuff. Or you're at the doctor's and they start, doing reflex stuff on you, and you're visually impaired. You don't know what's going on. And imagine the fear that you would have, and the trust that, you have to trust a lot when you're visually impaired or hearing impaired, because you don't have that sense. And you have someone just poking and prodding you, and you're like, what is going on? Again, survival instinct is going to get to flee, right? And so it's really, really important for different clients to, explain, hey, I'm going to touch your shoulder, and then I'm going to do this, and hey, feel this first. This is what I'm going to put in your ear or your mouth or whatever like that. And so they have that, because if not, they're going to resist you because they don't know what you're doing to them, right?
So who are some of the people that might be involved in that care team for these patients? So social worker, speech therapist, physical therapist, occupational therapist, psychologist or psychiatrist, teacher, pediatrician, dentist, parents and caregivers. Did I leave anyone out? Did I leave any specialists, but any areas out? No? Okay. The most important members of that team are the parents and the caregivers. So they can make things go super easy, or I won't say super easy, but certainly better for the patient, better for them over their development, but also better for that experience in your office. Because remember, it begins before they even get there. So the more that caregiver is informed and trained and knows what to do, it's better for all those people on that other slide.
And I think like what Bree was saying, that's where it's really imperative to have, like what they're doing up there is training those caregivers to care for those children in, a way that is safe and that is kind and gives integrity as well, or it's just so important.
So the next, I think is Autism Speaks. Are they here in this country, or are people familiar with the organization Autism Speaks? Anyone? Pardon? Autism Speaks, is that an organization that anyone here is familiar with? Okay. There's Autism Eswatini, I think. Yeah. Oh, is that you? No. Okay. She just appeared. So there is, I know, yes, in Manzini, and that group is doing a lot of wonderful things, and they were involved, I believe, when they had the World Autism Day here, that was big here as well. This is, it's actually kind of almost global, I would say. They're really trying, but they created this, and I don't know if this video will play, but it's basically a caregiving skill program, because not everyone has access to all of those providers that were on that list. In a perfect world, every kid, if they needed it, could get access whenever they wanted it, and that's not a reality anywhere. So if we know that the core member is the parents and the caregivers, because early intervention, early before they even get to see one of those specialists, if we can start the process and deal with what we see in front of us, then the outcome for the child is tremendously higher. So let's see, they might not be able to hear it, but. Can you make this?
The presentation.
How do I get it back?
So I think that just highlights the importance that we all play as caregivers and as not just parents and caregivers, but also as a community, that we all have a part to play in helping serve our greater community and being a resource for each other and making sure that parents, caregivers, doctors, teachers, PT, we're all working together to ensure that we are creating a world under which we are allowing to be inclusive to everyone. And by like my passion for I don't know what I'm trying to say, I'm tired, but my passion for real is just the tiniest adaptations that we can make in our communities can make a world of difference for these children who they just need the tiniest adaptation to be able to function and to roll like the rest of us. And we as a community should be obligated because the numbers of need are growing. And if we ignore that need, we're going to create a bigger problem for our society as a norm because we're not adapting and growing and we're shunning them out, and they're going to be a greater need on our society in a vacuum. And if we can just do the tiniest little adaptations to promote open-mindedness and welcoming to all of the populations, no matter where they're coming from, think about the world we could live in. And to me, that's the magic of what is humanity, is all of us being able to look at each other and say, I'm different from you, you're different from me, but you know what? Somehow we can all still get along and work together and live together in peace and harmony. And to me, that's like where this world needs to go. And we can all do that if we work together as caregivers for different populations and not ignoring it. So I'm going to get off my soapbox.
Good job, Lisa. Okay. So we've, yay, last night. So I can breathe now. So this is the opportunity for everyone now to do some talking and have questions. We can discuss. I would like to hear more on. Oh, go ahead. I see a hand.
Yeah, I have two quick questions.
Sure.
First one was something I believe it's Bree
Bree?
mentioned. You said there's something we can look up. Is it called BRIGS?
Oh, the Brigance. So the Brigance assessment tool is it's something that we use a lot in the school
Can you
systems.
spell it?
BRIGANCE. And what's nice about the Brigance is many educational, cognitive, intellectual kind of developmental assessment tools that are out there. You're only allowed to give if you have a certain level of education. So my Master's of Education allows me to do other testing. The Brigance can be done by anyone. And so up at Busanoka, they actually have the early identification program, which I believe is like down to a few months old, up to a few years ago, which is something that she's been really passionate about working and developing. There is another one for like the early primary levels. I know at St. Joseph's where I'm at, I was doing a lot of that at St. Joseph's. And that is just a great tool. It is a little expensive, but you can work around it. And I know, you have friends in the United States, so use those friendships, just saying, okay? Yeah, the Brigance.
Yeah, second question.
Another question.
Second question was, you mentioned something about reinforced behaviors. For example, when, I identify as neurodivergent. So when a neurodivergent child is in that dental setting, which is uncomfortable for all of us, I don't like mentioning dents either. You said we should not reinforce behaviors by allowing them to leave. But I tend to do that in my practice because I don't want a situation where the child stops saying I have a dental problem because of such a traumatic experience. Do you have any suggestions on how to go about that and not let them leave and get treatment done and maybe not traumatize?
I think it's the moment, it's like what happened, it's the timing, right? So if I kick that over or whatever, I act out and then I can just, okay, you're done, as opposed to taking a pause. Is there something that positive you could reinforce that they did so that they leave with, they got that accomplished, as opposed to, so you wouldn't let them, they wouldn't let you do X, right? Then you try to redirect, and I can't remember what that slide was, but you get to redirect that around and try to say, okay, maybe there's something we can do, and then we have accomplished that. So that they're dismissed out of an accomplishment, and you didn't address, like you didn't make a big deal about the negativeness of that, of what that behavior was, but you acknowledged it was uncomfortable. I'm not saying you don't. You acknowledge all of that had them upset, but then you try to bring that over to, is there something? And sometimes you can't. Like, I get that.
Well, I get what you're saying, because like you're right in the fact that, let's be clear, there's a difference between letting a child leave or letting a patient leave and them escaping. That's the big difference. If they throw it, to me, like as a teacher, if I have a student that's acting out, I know they're acting out because I'm going to tell them to leave, then that's escaping. And they're going to do that behavior every time it gets uncomfortable because they don't want to be in my class and they're going to escape. Versus me, or another day, I might say, hey, you know what? You've done a really good job. If you can just stick with me for 10 more minutes, I'll let you go to the bathroom.
Sorry, but some of us work with high volumes of patients, so we really don't have the time to do that. Not myself personally, but I mean, that is a discussion that is breaking out amongst us. How do we then manage that situation where we're supposed to credit you for not getting treatment and achieve something, but what you need to do is extract this tooth? Is there any?
That's a sticky wicket, right? That's the big elephant in the room, right?
We know that well. It is tough. It is tough. And is there a right answer or is there a wrong answer? No, like yeah.
It does work, it doesn't work, that has worked before, because sometimes it's really, when you've got a line, you might as well let them leave and come back.
Well, I think there's that time of like letting someone leave and come back, but having it be on the terms of like setting it up so they will come back, right? And that's what you want to do. You want to set it up so they will come back and they will return. So it's leaving on a positive as compared to like a punitive kind of thing where they escaped. It is hard. It's hard when you're running a business and it's about numbers and it's about getting those bills done and getting it done, right? So sometimes it might be, if and I think this is where it's imperative to know your client. If you know it's going to take a couple visits to get something done, then you say, okay, we're going to plan 5 10-minute visits throughout the week instead of a 50-minute visit all to go to chaos.
And maybe that visit as a doctor, that visit might not be with you, right? So it might be that they came in, they could see the office, even the mom. Okay, so here, look, this is the office. Okay, we said hello. Okay, that didn't cost, you didn't have to stop. They could come in again, and it's the front desk person greets them and says, oh, something sweet, something nice. Okay, then we go. Next time, somebody else might, so you have to play it the way you can. So, and this is where it gets into the whole, real world, right? So I get it. I look at some of that stuff and I go, what? That is not going to happen. So you really have to look at how you adapt and what are the little things you can do that make a difference. It really could be something small that makes a difference. But you thought about it, and that's where the pre-planning part comes in. So if you have access, if you can get that information, and it's not in every case that you can do that, depends on how your clinic is set up, right? Let me ask, how many people are here are like government versus, so how many people here work government or public health or whatever that is? So I know that group does, and here. Oh, thank you. Everybody else is private? Okay. So you have some control over in your private setting. So to the extent that you can, and let me acknowledge people here, the people that came because they were with us at the Richelieu Project for this week and doing their dentistry. So thank you. And I'm going to find that video. I promised her I would find that video from back in the day. So I just want you all to know that we saw it firsthand, right? We had an example of that, right? So none of us, there's no right, there's no wrong. It was just, we had different ways to try with this, we tried, and guess what? She got the tooth out, right? So it wasn't pretty, was it perfect? No, but it took conversation. It took some conversation and trust. And for this young lady who's not neurodivergent that I'm aware of, but she was scared to death. She might as well have been, right? So the behavior was there. She was doing all of the other stuff, grabbing, and when they want to grab the syringe and all, they're like, what are you doing? So that was a person, but they had a big need, and it was like, okay, we like, this got to happen, So I'm negotiating, I'm trying all these other tricks, and she's like, maybe, but then actually she did want to get it done, right? So she chose, and she did, right? Screamed, but she got it done. But that was what it took. So sometimes it's not pretty. It doesn't look like it. It looks all over the place. So yes, sir.
Thank you, Louise, for the beautiful presentation. I would say thank you for coming at such a perfect timing, because I've just been working on a patient what's of a spectrum. I'm not sure if I would be correct if I would say ADHD is the upper end of ASD. Now, my question is, if you happen to come across a patient who has lack of cognitive skills, language, motor skills, and social skills, who is hyperactive, right? Like now I have a case in the ward of a patient who have been operated yesterday, and he has those deficits, right? And now managing the patient in terms of IV medication, the dressings, though we try to restrain him, it's a bit of a challenge. Can you share with us or with me as to how you manage those patients? You've mentioned something on pre-operative,
Right.
Intra-op will be under general anesthesia. Post-op, that's where we experience these challenges, which are really bad. Now, can you share on what maybe you have seen being done? Because in your presentation, I haven't heard on anything on restraints. You see, like, to give you an example for this young man, we had to use ketamine to play with him to relax him before we could even take blood samples.
Right.
It's not every center that will have those facilities. And I haven't heard you talking about forms of restraints with which they've been talking about to manage those patients. Not only autistic patients, but we have other conditions like trisomy 21, whereby you have difficulty in controlling those patients. I don't hear you dwelling on those restraints, the safer ones.
Right. Well, I say 5 years ago, I may have had an answer for that. I don't have a real answer for that, only to say that I think it depends upon what, from a tactile situation, I would just kind of use an analysis of that. Like, well, what are the triggers for this patient? You said that they're deficient in a wide variety of areas, so it's almost that person can't communicate with you and say, I don't like, they can only respond. So I don't have a magic answer. I know that there are safer ways to cocoon them, to protect them. I had some slides of that a few years ago. I don't have that with me right now.
So I can say, like, for me, it should be a least restrictive environment, period. Maybe this is a teacher in me coming out. Restraints are not a least restrictive environment. It should be a last case scenario safety issue, right? Now, there are ways around that. Like, I think to myself, like the other day we had the visually impaired young lady who was freaking out and scared, and she was resisting and she was flailing. She couldn't see anything, poking, prodding. I knew her. We used to sing together. I came and said, hey, would you do this if you sat on my lap and I hugged you? And she said, yeah. And I literally sat on that dental chair and she laid on top of me and I bear hugged her and I just kind of like gave her the little loving motherly nurture and said, you know, I'm so proud of you. You're doing a great job. Open up. And she got the job done. And it, you know, sometimes it's just that relationship piece. For some of the people with cognitive, it is a lot of trust. You know, for the cognitive piece, I mean, think about how traumatic it is to be restrained and have someone poking you and you don't understand what's going on and how to navigate that, right? And so I think that's where we as a community have to get better, and that's why we're doing this, because I don't have an answer, but I think this is where we as a community have to come together and find an answer of how to best navigate that, because can you imagine the trauma? I mean, how'd you feel if I came over there right now, like put you in restraints and like started doing stuff to you that you didn't know I was doing? You would be flipping out, right?
Yeah, I understand.
Yeah.
I'm talking about lack of cognitive function, language. You can't communicate to the patient. So you can't actually give an instruction.
I think that's where we need to be creative about it, because there are children that let me finish and then you can ask, because maybe I can answer. I see at St. Joseph's all the time. There's a girl, CPA, there who, when she first came, she would grab, she was aggressive. She just would make these noises that no one understood. She's got really a lot going on. We just needed to be creative about giving her that outlet to communicate in a way that she was able to access the communication. We all have a way to access communication. We just have to figure out how to do it. And that's where we need to find that. And I think that's a lot of where the training at home can come into place. If, like, I think about the student, if they are this patient, if they need to be restrained, then maybe there's some ways at home where they can like show them like how to do it, pretend to do the blood work, to do those kind of things, so it becomes a patterned behavior of understanding instead of something that's coming out in this traumatic piece of paper. I mean, I don't know the answer to that. I really don't. I don't think any of us do. There's no magic bean per se, but I think to be creative and thinking about how we can do it and use things like the restraints, even though they're necessary sometimes, because they are, but to use that as a last resort, because I mean that just causes so much trauma.
Okay, thank you for that. Now, if I may ask or maybe suggest, like the last exercise we had here at St. Joseph's, did you impart those to the caregivers, the teachers, the technical know-how of managing these patients? Because what I've seen in my practice, years of practice, is that the caregivers or parents, they've got no clue on how to handle these children. Right. Do you find it important and necessary to train the caregivers and patients or the kids that you see?
Yeah,
100%.
That's why I had the most important person on the team, on the care team, is the caregivers. So if you can intervene there and educate them, and that is going to have the ripple effect for all of everyone else, right? So that's why I wanted to bring that up to the group, because if people are asking for that, pushing for it, it's only going to make things better, both by the time they get to where they need to see you, both for the kid to get early intervention, the teaching of them, or however way outward you all can do to educate the community. Like, I think I told him I wanted that slide to explode, because I'm like, this is it. This is the answer to everything right here. You know, like, get that early intervention, have those caregivers involved and trained. They should, you know, so they don't have to just drop them off at the door and say, take care of them, right? So like, how do you solve that? You know, I know that's a bigger problem, but how do you solve that? No matter where you are, that's an issue.
Yes. I think also to kind of add to that, when you're talking about your families, whether they have that knowledge or lack of knowledge of how having to deal with their child who is on that broad spectrum, whether they know it or not, they are the ones who have been with this individual since they've been born. So they know their tics, whether when they are agitated, they're nervous, they need that small support system, whether that be standing by their sides or then taking that small knowledge of who they are and what they like, what they don't like, how to process those things, and then take that to then give it to that doctor, whether that be that physical therapist, that dentist, that doctor saying that maybe let's not shine a really, really bright light in my daughter or son's eyes because that will set them off. They might not have that verbal communication, but they know hand cues. So the difference between gentle as a soft hand or holding on really tight, or to be relaxed or to breathe. So those small things, whether that child might know how to communicate, whether we think that they might not communicate or not, as a caregiver or as a parent, a brother or sister, an aunt, a nephew, an uncle, like we know the things that that person within our family deals with. So whether that parent, has that lack of training, they might think that they have that lack of training, but it's all that instinct that they've had with that individual throughout their lives.
That kid has trained them.
Well, we all know, like, that baby, when your baby cries, if it's a tired cry, or if it's a hungry cry, or if I need attention cry, or I just jumped off the bed and I just bumped my head cry, right? You know the difference between the cries. Everybody has a way to communicate, but I think we do, as a community, again, have a responsibility to better each other. And that includes parents and caregivers. They only know what they know. And until we teach them the other side of things, then they know more. And that's what Bree is doing up there at Busanofo. That's what I do as a teacher. But I don't expect it to stop there because I'm getting knowledge from the parents as well. I'm getting knowledge from doctors all the time are sending me notes about my students. And that makes me a better teacher for them. So if we work as a community, as a collaborative, then we can better serve all these students and get what we all need to get done.
Thank you. There are some questions coming on the online group. So I'm just going to read some of them out. The first one says, from Prison Doctor, says, what is your take on the diagnosed autistic clients admitted at the correctional facilities, especially in the juvenile section? Do they deserve to be released on medical grounds, or do they deserve to serve their sentences up to the end?
That was a loaded question.
Okay, so my first response is 99% of the people there probably have some sort of neurodivergent diagnosis. But so to say autism would be pulled out of that for that reason, in the U.S., no. In the U.S., that would not happen.
So they should serve their sentences.
They're going to show. Yeah.
It's a very political question, though. I mean, it's a very political and cultural question.
It is.
Yeah.
U.S. We don't have. They used to have places for people that had mental disabilities to go. Now they have prison. They go to jail. They go to prison. That's where they go. They don't have those homes and things.
Okay. The next one's a statement, but is a question. Please share with us how to help teenagers with ASD to transit into adulthood, help them live independently and responsibly.
That's key. A couple of years ago, I spoke in Vietnam and was speaking to parents about the transition between childhood to teenagedom to adulthood. And what's really important is that when they are younger, to make sure that you're reinforcing behaviors that you want to see in them as adults. So for one of the parents there, they thought it was really cute that their little girl was running around they were all cute and they were just so cute and they were running around naked and everyone was like, oh, you're so cute. And I'm like, and you're reinforcing the behavior. So now they're going to be 15 years old running around naked thinking they look all cute. What do you think is going to happen to that little girl? Now they're 24 and they're running around all naked because they think it's all cute and they got its attention, but now they don't understand why the attention has changed. What do you think is going to happen to that little girl? Right? So I think it's really imperative that when you have these children who are still trying to get help in navigating our world and our cultures and our community and our social norms, that the more you can teach them at a younger age of what you want to see in them as adults, you're going to give them a better opportunity to be productive adults. So like I work in high school, so I work with students who are in teen. Well, you know, we all know teenagers, they're not all together right ever, right? And so you are constantly, no matter if you have a teenager that's quote unquote average or not, you're constantly having to train them to be adults and to be productive adults. And so you've just got to start that very strategically and diligently with students and giving them those expectations like you would any other child. You want them to be as independent as they can be and provide them the least restrictive environment as they can live in, because everybody deserves a chance to have freedom and to experience independence in their life, right?
All right, so there's more questions. All right, this first one has been answered already, but I think I'll take the second one. How should parents discipline their child with autism?
Well, that's very cultural too, isn't it? Because I know in the United States, it's probably very different than what I've seen here. And so there's a cultural piece to discipline, and culture has to be respected because that's what culture is, right? I think though, the more you understand autism or any other disability, the better you are able to control behaviors that you're going to see with that. And so I think that's where it's really important for caregivers and parents to understand their child and what they're dealing with, so they can better assist them into growing up to be those adults that need to be functioning. So, I don't know if there's a really.
I just got this hook. Oh, I'm sorry. Thank you. I have to. We need to call time on here, and they want to bring.
I'd just like to echo Dr. Joseph's sentiments in terms of his appreciation for this opportunity, in terms of getting to know our autism and things like that. Mine is hopefully not, I'm going to say you're going to find the question. We do get a lot of these clients coming into the clinic, and you find that, well, previously you'd find that we're not aware that you're dealing with an autism client. Maybe you just assume that maybe it's a child that's acting out or anything like that. And if now you're going to be someone who's going to be in a position who can confidently say that maybe this is autism, the parents would like to know further. And in knowing further, my question is, have you had instances whereby maybe the autism started later on in life, or maybe treatment was, or in some cases whereby the autism started when the child was young, there was intervention, and then the child got back to something you call normal? Have you had those cases? So that maybe because most of us just see clients in the public sector, and in those conversations with the parents, maybe you'd like to give some reassurances that, you know what, if you intervene early, there is hope that this child can revert to what we call normal, or something like that. You just make a comment. Thank you.
Sure. I mean, I think anything that goes with neurodiversity, just in general, that just not even just autism, but anything in neurodiversity or anything that sometimes it ebbs and flows. Right? Like, if you're someone who experiences Tourette's syndrome, it's not like it's happening 24 hours a day. Sometimes you have your tics start to happen when you get anxious or you're happy, and then it subsides, right? So it's, some of these neurodivergent experiences are on a scale and they slide, right? And I think the better we understand it, and the better you understand who you are and what you're experiencing, and better caregivers, you can better give your children or your clients coping skills to navigate the world around them. And so, like I said, we all have tics. We all have little strange things we do, just with people with autism. We've learned how to navigate the world and how to cope with it, right? So we have to allow and give our children, our patients, our students coping mechanisms to navigate through that, and that we all need to do that together. And so I think
say goodbye.
That does ebb and flow, and it's going to be hard and it's going to be soft.
Okay. We're going to say goodbye to our friends on the, what do you call it? It's not
Google
Zoom.
Meet.
Google Meet.
Google Meet. So to everyone on the Google Meet, sorry, I called it Zoom. I want to thank you all for attending, for being a part of this discussion, and certainly look forward. And I do hope that it was helpful, and I'm seeing that the presentation is helpful. Thank you for that. It's a conversation to be continued and often. So I charge you all with that, and thank you all for inviting us to come and give the presentation.
And we'll be sharing resources.
Oh yeah, and we'll be sharing resources and the
Slides.
And we'll look at the chat to see if maybe we can highlight some resources that address the questions in the chat.
Okay.
All right. Good night, everyone. I think that's the end of the presentation.
Okay. Thank you. So,
Good
yeah.
night.
So we're gonna make sure the food is going to be on its way. We can certainly take questions. We can certainly discuss, because really amongst